Thank you. I have the privilege of being Dr. Choi's partner. I don't know if he mentioned that, So thanks to Dr. Lemasters and him and Sages for inviting me. My disclosures, and none are really pertinent to today's talk. So, as we know, obesity is a global epidemic and continues to get worse. Just in America, the CDC predicts that we spend $147 billion every year treating obesity-related health diseases. And so far, the only and best tool that we have to treat that is surgery. And, I always say the sleeve is still king because it accounts for 50 to 60% of all the primary procedures that are done in our country today. And if you can look at the bar graph here, and you see the dark blue lines are sleeve gastrectomies, and ever since the early 2000s, when they became indicated for a primary procedure, we've seen this kind of steady increase year after year, except for COVID. This is 2020 data. And so the other thing to notice is this light blue color is rising as well, which are revisional surgeries in America as well. And so I think the question that we need to ask ourselves, is sleeve a good operation? Are we serving our patients? And is it a durable for weight loss? So it's all in the definition, right? So these are the words you're going to see: weight recurrence, weight recidivism, weight regain. And how do you define that? And I think the Power Task Force from ASMBS did a great job trying to look at this problem, because if you start reading the literature, it's very confusing, and all kinds of different definitions are being used. So what do you pick? What's going to kind of drive you to revise these patients? So when asking the question, is sleeve a good operation? Is it a durable operation? That's the question that Dr. Clapp and his team set out to answer, right? And so did this meta-analysis, 9 studies, 652 patients with at least a 7-year follow-up. So they were trying to look at a longer-term outcome. And as we're talking about definitions and saying how important they are, they defined weight recurrence as initially losing 50% of their excess weight, but then having regained weight to have at least less than 50% excess weight loss. So in this study, the weight recidivism was almost 30%, okay? And 20% of those people ended up requiring revisional surgery, and over half of those were for weight regain. So as we answer that question and we start selecting our patients to revise, I think it's important to do a very thorough workup on them. I think reviewing all operative notes, getting history from the patient and seeing what kind of additional procedures they may have had. One of the big things I think is important for me is their history of their weight regain. I often find that there's some sort of trigger in a lot of folks. It may be social or psychological, and so that's why I think it's so important to have a multidisciplinary team involved in their evaluation. Anatomical evaluations are critical as well. I do an upper GI and EGD on all my patients. If patients have had prior hiatal hernia repairs and we have to fix it again, or if they have twists in their sleeves or strictures, also may impact what revisional option you choose to pursue. Certainly, if you see something like the bottom right there where somebody has Barrett's, it might really impact you to kind of take them more towards a bypass route. And then, lastly, have a very kind of candid discussion with your patients. Generally speaking, you get in there to do a revisional case. Some are pretty easy and straightforward, but others can be very challenging. And so at a minimum, there's increased risk. I always, being a prior Army guy, I have plan A, plan B, and then like my plan for retreat, so. When it comes to revisions, it's really pretty straightforward. You can take a sleeve and re-sleeve it, and you can turn it into a gastric bypass or a OAGB or a switch or SADE. So probably not the best of choices. I think as we were early in our experience with sleeve gastrectomies, this was a pretty common thing that had to be done to re-sleeve patient. Fundance was done, but we do have some data that looks like they do initially pretty good, but after 2 or 3 years, it typically regain their weight. So I think as our knowledge of this procedure has increased, we've gotten better and realized that it's probably a better idea to add a malabsorptive component instead of to just redo the same operation. So probably wouldn't recommend that. Next, sleeve to bypass. This is by far the most common revision of a sleeve, and it's technically more challenging. You have to contend with hiatal hernias sometimes, staple lines. If your sleeve is twisted, you may have to do a little additional work when you're doing that. If you get your hands on these operative reports and things are not always like they seem, any concerns, sometimes I'll get a CTA ahead of time to kind of check the blood supply and if there's a left gastric problem. Intraoperatively, I think there's a role for ICG, arteriography, and you can use that, and that sometimes can be helpful. And certainly I think this is probably the primary choice for people who may have weight recurrence but also have GERD. And I don't really do OAGBs, but I think that's really just an offshoot of this operation. And last, sleeve to switch or SADI, also kind of on the levels of complexity, we're getting a little more challenging here. There's going to be a little higher complication rate, both perioperatively as well as potential complications for nutritional issues down the road with your patients. We talk a lot about SADI and switches and all that stuff, and we were doing them in fellowship a long time ago, but they're still pretty uncommon. If we went back to that initial slide, you can barely see all those as the primary procedures. So, I think it's something we really got to consider and see if we want to adopt that into our practice. And then the caliber of sleeve is important. We generally make a 36 French sleeve when we're doing our sleeves, and that's probably a little smaller than you want if you're going to do a switch or a SADI. So even though this may seem like an easier choice sometimes because half the operation is done for you, you may need to go back and fix what somebody else did or maybe what you did. And so what are the outcomes? And I found this to be a very good and interesting study out of Nice, France. And they did a meta-analysis of 39 international studies over 14 years. And so, and they wanted to see what were the outcomes of revising failed restrictive procedures. So they looked at sleeves, they looked at bands, and that was the majority of it, but there were some VBGs in there as well. And their primary outcome was looking at weight loss for a revisional surgery with secondary outcomes looking at complication rates as well as weight regain, which was pretty interesting. So, complicated slide, okay? But if you just look at these forest plots, down here at the bottom, I'll direct you to, this is total weight loss after 1 year and total weight loss after 3 years, okay? And kind of the comparison is going to be sleeve or re-sleeve. And not very surprisingly, as you start looking long-term, switches and SADIs are going to get the best outcome. I was surprised that bypass came in last. When you look at 30 and greater than 30-day mortality, again, it didn't surprise me that switch has the higher risk rates. What did surprise me again was that bypass increases with time. And SADI and OAGB are very comparable to a sleeve or to a re-sleeve. They found SADI to be the best in terms of weight regain. This is over a limited time period, of course, as a revisional operation, followed by DS and Roux-en-Y gastric bypass. So their conclusions is pretty straightforward. Switch and SADI had the best short and long-term weight loss at 1 and 3 years. SADI was the best procedure when it came in terms of weight recurrence. DS has, as we all know, probably a little higher early and late complication rate, and re-sleeve is not a good idea. I think the things that surprised me the most were for bypass, which is probably my main go-to revisional operation, and that had greater complications than all other operations other than the duodenal switch. And it had limited weight loss long-term, or 1 in 3 years. I keep saying long-term, but only 4 and 7% compared to sleeve or re-sleeve. So in their conclusions, they thought that SADI and OAGB were the best and balanced operations when it came to revising restrictional procedures. So in summary, I think sleeve gastrectomies are a great operation. I think we still need to look long-term and what's going to be the future of this. We're going to continue to do them because they're easy and they have a low complication profile. But I also think the more we do, the more we're going to be revising. So I think if you're going to do these revisional cases, you really need to spend time with your patient. You need to put them through an entire comprehensive workup and see if you can hopefully set them up for success the second time around, and if you can maybe identify what were the key things that were missing the first time. And understand that obesity is a lifelong disease process, right? So we're going to have to follow these patients forever, and they're going to require reintervention as time goes along. And then, you have to pick your revisional option based on your experience and based on your discussion with the patient and what their tolerance is for risk. So I don't think there's any great perfect operation for every patient. I think you really have to look at things individually and make the best decision for them and for you. I think Dr. Choi's office is right there behind that tree. Yeah. Thank you.